Now let's talk about how all these hormones interact with each other when someone is experiencing heart failure. Now let's imagine that we have a patient with left-sided heart failure. Now what does that mean? It means that the left ventricle of the heart is not able to pump blood strongly enough so as to maintain a physiologic value of the cardiac output. This can be because of a number of causes. For example, there has been myocardial infarction to some part of the left ventricle, causing that part of it to be weaker. It could be because there is an infection of the heart, with a lot of white blood cells infiltrating the heart, impairing its function. It could also be because of an autoimmune disease, because of arrhythmias, etc., etc. But the end result is basically the same. The left ventricle is not able to pump blood strongly enough. So let's look at our flow chart. It has a lot of the stuff that we have mentioned already, starting at box number 1. For whatever reason, left ventricle is weakened. This leads to inadequate cardiac output. Now let's move on to box 3. If you remember your physiology equation of how to determine mean arterial pressure, we need to multiply cardiac output by the systemic vascular resistance, which will give us mean arterial pressure. In box number 3, we have systemic arterial pressure, which is basically synonymous with mean arterial pressure for this context. And we just said that cardiac output is not as high as it should be, it is lower. Therefore, if you lower the cardiac output according to the equation we just discussed, mean arterial pressure will be lower. And the reason behind this is that there is less blood being pumped into the arterial system. But we did not mention anything about not having enough blood in the body. We did not mention anything about not having enough intravascular volume. So there is blood, but it's not in the arterial system. Then where is it? It is more than it should be inside the heart, which is why blood accumulates in the chambers of the heart, and then it also accumulates inside the veins of the pulmonary circulation. If it cannot go forward, it has to build up somewhere. And that is what leads us to box number 4, pulmonary venous pressure rises. It is the volume of blood that rises and consequently the pressure. What does that lead to eventually? It leads to pulmonary edema. It means that this increased amount of fluid inside the vessels, causing increased hydrostatic pressure inside the vessels of the pulmonary circulation, eventually leads to fluid moving out of the pulmonary circulation into the interstitial space of the lungs, causing the pulmonary edema. Pulmonary edema basically means fluid inside the lungs, not just inside the vessels of the lungs, but in the interstitium of the lungs and eventually even inside the alveoli themselves. Pulmonary edema eventually leads to right-sided heart failure. Now, why is that? The right side of the heart is pumping blood into the pulmonary circulation. If the pulmonary circulation has a high amount of blood and then a high pressure of blood, then it means that it is harder and harder for the right side of the heart to pump blood into this circulation. So the right side of the heart, the right ventricle that is, tries to compensate. It is trying to pump with more and more force, and at the beginning it is doing fairly well, but at some point it starts getting tired. There is not enough oxygen to equate the increased demand for activity, so maybe at some point there will be myocardial infarction, or even if there is not myocardial infarction, overall the heart is being weakened, and with time we have gotten right-sided heart failure when we actually started with left-sided heart failure. What does the right-sided heart failure lead to? It leads to the fact that now not only blood is not able to be pushed forward from the left ventricle, now blood cannot be pushed forward from the right ventricle also. So blood accumulates behind the right ventricle, and where is that? It is inside the systemic venous system, inside the superior and inferior vena cava and all the veins that drain into these big venous vessels. So systemic venous pressure rises is what happens, as we can see in box number 7. And if the systemic venous pressure rises, then there will be systemic edema, which is basically the swelling that you can see in the ankles, for example, of patients with heart failure. This is just the pathophysiology of heart failure for you to understand what is happening in someone's body when they're experiencing this disease. And now we will discuss the various hormones that try to compensate this pathologic pattern, and we will say which ones the hormones are and what each one does specifically on the heart and on the vessels and on the kidney. The parareceptor reflex is one of the mechanisms by which the body tries to compensate for the failing heart. As we said previously, when the heart is failing, the systemic arterial blood pressure is below physiological level. As a result, stretch receptors found in the aortic arch and carotid sinuses are not stretched as much as they would be if the arterial blood pressure was at physiologic levels. What this means is that the receptors will be inactivated. These receptor cells are connected with certain nerves, particularly cranial nerve 9 and 10, and when the receptors are inactivated, it means that the nerves will be firing at a lower frequency, i.e. fewer action potentials per unit time. This decreased frequency in action potentials will be picked up by the solitary nucleus. The solitary nucleus has connections with the vasomotor center in the medulla oblongata, as well as the nucleus of the vagus nerve responsible for autonomic control of the heart. An inactivation of the parareceptors means that the solitary nucleus will be also not stimulated as much, and when the solitary nucleus is not stimulated as much, there is connections to the vasomotor center, allowing it to be stimulated, and there is inhibition of the nuclei of the vagus nerve involved with autonomic activity of the heart. As a result, stimulation of the vasomotor center means there is an increase in sympathetic activity, and inhibition of the nucleus of the vagus nerve means that there is a decrease in the parasympathetic activity. The consequences of increased sympathetic stimulation and decreased parasympathetic stimulation exist both on the heart itself and the blood vessels. The effects on the heart are: number one, positive inotropic effect, which means that the heart will now be able to contract with more strength. Number two, positive chronotropic effect, which means that the sinoatrial node will be able to depolarize at a faster rate to help achieve a higher heart rate. Number three, there is a positive dromotropic effect, which means that the atrioventricular node will be able to conduct action potentials at a faster rate, also in order to achieve a higher heart rate. And number four, there is a positive lusitropic effect, which means that the heart will be able to relax faster during diastole, so that even though the heart rate is increased and the duration of diastole is decreased, the heart will manage to relax to the same or at least a similar extent than if the positive lusitropic effect would not exist. As for the effect on the arterioles, smooth muscle of arterioles will contract, and this will result in arteriolar vasoconstriction. As we said previously, whenever there is a decrease in blood pressure, what we want to do with the blood vessels to increase the blood pressure is vasoconstriction. And as you can see in our flowchart, all the effects on the heart will lead to an increase in cardiac output, and all the effects on the arterioles will result in an increase in systemic vascular resistance. And as cardiac output multiplied by systemic vascular resistance results in mean arterial blood pressure, and we are currently aiming for an increase in cardiac output and an increase in systemic vascular resistance, that means that automatically we will be achieving an increase in systemic blood pressure. Another system in the body that tries to compensate for the failing heart is the renin-angiotensin-aldosterone system. We have talked about this briefly, now we will do so in more detail. Adrenaline, the hormone of the catecholamine type that we mentioned before, as well as the decreased perfusion of the kidney, both will stimulate the kidney's juxtaglomerular apparatus to produce and release more renin, the enzyme and also hormone that we talked about before. Now, the function of renin specifically is to convert angiotensinogen, which is found in plasma, to angiotensin 1. Angiotensinogen is a peptide that is constitutively all the time produced by the liver and released into the plasma. Once we produce increased amounts of renin, then it means we are converting angiotensinogen to angiotensin 1 at a higher rate. That means we're increasing the concentration of angiotensin 1 in the blood. Angiotensin 1 will go on to be converted into angiotensin 2 by an enzyme known as angiotensin converting enzyme. This is an enzyme that is found on the surface of epithelial cells all over the body, especially in the pulmonary circulation. The reason for converting angiotensin 1 to angiotensin 2 is that angiotensin 2 is more potent. They have similar functions, but angiotensin 2 is stronger in bringing about these functions. And now we'll talk about the functions of angiotensin 2. It has two major roles. Number one is that it acts on cells of the zona glomerulosa of the adrenal cortex that produce aldosterone, and it stimulates the production of aldosterone. It basically acts as a catalyst to the production of this steroid hormone. And then the aldosterone will go on to stimulate sodium and water retention, as we explained in the first slides when we were talking about the hormones acting on the kidney. At that time, we mainly emphasized the increase in sodium reabsorption, but please remember that aldosterone is acting on the distal convoluted tubule, collecting tubules and collecting ducts, which are permeable to water. So, since sodium will be reabsorbed at a higher rate, and at that part of the tubules, water freely follows sodium. Where sodium goes, water will follow. Sodium will be reabsorbed more, then water will be reabsorbed more. And as a result, as our flowchart shows, the increase in sodium and water retention will result in an increase in the volume of body fluids, including intravascular, which will be helping in increasing the systemic blood pressure. Now on to the second effect of angiotensin 2, which we have also talked about. Angiotensin 2 stimulates arteriolar smooth muscle to contract. This means that there will be arteriolar vasoconstriction, increasing the systemic vascular resistance and also helping in increasing the systemic blood pressure. This is a flowchart which explains in detail how antidiuretic hormone also plays a role in trying to compensate the decrease in systemic blood pressure during heart failure. I will not go through it as we have done so while we were talking about ADH in the first section of this presentation, but please do go through this flowchart on your own. And also try to remember that ADH as well as aldosterone, even though they are increasing the systemic blood pressure by retaining water, and they are in a way trying to help perfusion of organs since the heart is not so much well able to do so, at the same time they are worsening the situation going on inside the heart, because as we said, the heart is overfilled with blood. And by increasing the intravascular volume, yes, you are increasing the amount of blood in the arteries going to the organs, but you are also increasing the volume of blood inside the heart and inside the veins, so you are exaggerating and therefore worsening the pulmonary edema as well as the systemic edema. This flowchart explains how ANP and BNP are also involved in the compensatory mechanisms during heart failure. Again, we talked about this during our first part of the presentation, but I encourage you to go through the flowchart on your own time in more detail on this slide. Now let's talk about thirst. Here we can see that thirst is increased in heart failure. This is a very interesting fact that I have found, but unfortunately we're not sure how this mechanism is brought about, which hormones are involved, which receptors are involved, etc. What we know is that in a way it accompanies and it complements the ADH system and the RAS system in trying to increase intravascular volume, in order to increase blood pressure, but at the same time worsening the edema. Now that we talked about all the hormones produced and acting on the cardiovascular system and kidney, as well as how these hormones cooperate with each other and act on these systems during heart failure, let's do some revision on everything that we did in this presentation. Let's start with question number 1, which says, which of the following normally causes either renal sodium or water retention during compensated heart failure? A. Decreased angiotensin II formation. B. Decreased aldosterone formation. C. Sympathetic vasodilation of the afferent arterioles. D. Increased glomerular filtration rate. And E. Increased ADH formation. In this question, you basically have to remember all the mechanisms that you learn about what is going on during heart failure. You have to remember that during heart failure, the heart is not working properly, i.e. there is a decrease in mean arterial pressure, and the body is trying to compensate by trying to increase the mean arterial blood pressure. So everything that is going on is with the final goal of increasing mean arterial pressure. And then you have to remember which hormone does what. So angiotensin II increases blood pressure, so it would not be decreased in your attempt to increase blood pressure. So A is wrong. Then aldosterone also functions to increase mean arterial blood pressure, so again it wouldn't be decreased in your attempt to increase systemic blood pressure. C. Sympathetic vasodilation of the afferent arterioles. This is not occurring because even though there is vasodilation of the afferent arterioles by ANP and VNP, the sympathetic system does not vasodilate the afferent arterioles, it vasoconstricts the afferent arterioles in order to maintain water inside the body, in order to decrease GFR, that is, to maintain water inside the body. D. Increased glomerular filtration rate. That is happening through ANP and BNP, but that is in a way so as to counteract the excessive activity of the renin-angiotensin-aldosterone system. So it is to balance the compensating effects so that the compensating effects are not too much. So the increase in glomerular filtration rate is not a compensatory mechanism itself, it is what counteracts the compensatory mechanism so that they don't go out of hand. I hope this makes sense. And the final, so that is also wrong. And the final answer, E, increased ADH formation, which we have learned and have talked about it during our clinical correlate. And indeed, ADH is increased during compensation of heart failure. And out of the two options that are given in your question, causes either renal sodium or water retention. ADH, when it is increased, it causes increased water retention. Here you have available a small summary explaining all the points that we referred to as we were going through all the answers of question 1, and you can go through it at your own time and understand even better why all the answers from A to D were wrong and why E is the correct one. Let's continue with question number 2. A 65-year-old man with a 5-year history of congestive heart failure is being treated with an angiotensin-converting enzyme ACE inhibitor. Which of the following sets of changes would be expected to occur in response to the ACE inhibitor drug therapy? Now, as a second-year medical student, seeing a pharmacology question may at first feel stressful. You may ask, why are you giving me a pharmacology question when I haven't done this subject yet? Well, the answer is simple. You do not need to know anything about the drug itself to answer this question. All you need to know is the physiologic function of the enzyme ACE. Once you know what it does in the body, then you can very logically infer what will happen in the body when you inhibit this enzyme. And this is exactly what this question is asking you. So, what do we know about angiotensin-converting enzyme in terms of angiotensin II, for example, the second column? ACE converts angiotensin I to angiotensin II. So when ACE is activated, when it is working, when it is doing its job, there is an increase in the level of angiotensin II. But if you inhibit ACE, you prevent conversion of angiotensin 1 to angiotensin 2, so clearly ACE inhibitors will decrease angiotensin 2. Now, angiotensin 2 helps to increase arterial pressure, so if you decrease its amount, you will also decrease arterial pressure. And total peripheral resistance is in fact what the angiotensin 2 is affecting in order to achieve an increase in arterial pressure. So if you decrease the angiotensin 2, which is causing total peripheral resistance normally, then it means you're decreasing the total peripheral resistance, which means you're decreasing the arterial pressure. This means the correct answer for question 2 is E, the one that includes a decrease in all of the 3 parameters provided to us. On this slide, you can see the answer that we just discussed in a bit more detail. Question number 3. Which of the following sets of physiologic changes would be expected to occur in response to an increase in atrial natriuretic peptide? So this is a more straightforward question. It asks you for the physiologic functions of atrial natriuretic peptide. And as we've learned, A and P along with V and P inhibit the RAAS system, so angiotensin 2 should decrease and consequently aldosterone should decrease and sodium excretion should increase because ANP has as one of its main functions to increase sodium excretion, which in a way also counteracts the RAS system, as the RAS system does have as one of its goals the increase in sodium reabsorption, not sodium excretion. So RAAS system increases sodium reabsorption, ANP and VNP increase sodium excretion. Increase reabsorption, increase excretion. So they counteract and balance each other. Here is answer 3. The correct answer from the previous options is H, as we discussed, and you can read it through on your own also. Thank you very much for your attention. If you have any more questions, you can of course contact me through any of my social media accounts. This presentation was quite long. These concepts are quite complicated, maybe some of the most complicated in endocrinology, but they are very, very important. These are concepts that you will be coming back to throughout your medical career, and you need to grasp these concepts as well as you can starting from now, because it will pay off and it is not something that you can escape from, no matter how hard it may feel at first. But keep having contact with the material, and slowly, every time you read, every time you do questions on them, you will understand something more, and at the end you will grasp it and you will never forget it. And here are the references I used to produce this presentation.